In 1978, the American Society of Regional Anesthesia had the pleasure of presenting to Dr. Torsten Gordh the coveted Gaston LABAT Award for his pioneering work in regional anesthesia. We've asked Dr. Gordh to be with us today to recreate that presentation and the lecture he gave on that occasion. Torsten Gordh received his medical degree in 1935 from the Karolinska Institute in Stockholm, Sweden. His desire at that time was to be a surgeon, and he was the youngest of all of the surgical residents of the world-renowned Professor Gustav Söderlund. At that time, there were no anesthesiologists in all of Sweden, general anesthetics being administered by nurses, and locals and spinals by the surgeons themselves. As the youngest of the surgical residents, even though he had no anesthesia training, Torsten was frequently elected or delegated or relegated to the administration of anesthesia. Visiting surgeons from England had noted upon several occasions that surgery at this time in Sweden was outstanding, but the anesthesia was not so good. Professor Söderlund wished to improve this situation and asked Torsten if he would be interested in devoting himself to this new specialty of anesthesiology. Probably as a means of protecting his surgical ambitions, Torsten agreed to at least think it over. In the fall of that same year, the eminent British anesthesiologist, Michael Noseworthy, visited Stockholm, and Torsten made an appointment to talk with him. After a long 6-hour interview with Dr. Noseworthy, in which the entire story of this rapidly developing specialty of anesthesiology was presented to him, Torsten realized the tardiness of his country and the necessity of its advancement in order to be in the forefront of anesthesiology as it already was in other phases of medical specialization. Noseworthy very promptly arranged for Torsten to train in the department of Professor Ralph M. Waters in Madison, Wisconsin. The young convert to the specialty of anesthesiology arrived at the University of Wisconsin in October of 1938 and remained there until March of 1940. During that time, his enthusiasm and his interest became all-consuming, and he became highly proficient in the skill and knowledge necessary for the practice of anesthesiology. But perhaps more important, he really dedicated himself to the advancement of that specialty. Upon his return to his native Stockholm in 1940, Dr. Gordh assumed the first position of an anesthesiologist in the entire nation, created at the newly established University Clinic of the Karolinska Hospital at the request, of course, of Professor Söderlund. He entered his new position with enthusiasm and eagerness, and in the course of his practice, even the royal family, including the King of Sweden, came under his care. Besides introducing the teaching of clinical anesthesia to medical students, Torsten trained many young anesthesiologists who went out to practice all over Sweden, as well as in the other Scandinavian countries. And of course, many of these young men became chairmen of departments of anesthesiology themselves. Then came his appointment as docent in anesthesiology at the Karolinska Institute, and his research since that time has led to the publication, up to the present date, of more than 120 papers. Perhaps Torsten is known best over here for the fact that in the 1940s he introduced xylocaine into clinical practice, and it was he who first gave a rational explanation as to the cause of spinal headache. But as you will see in a moment, his inquisitive mind continues to study and add to our understanding of regional anesthesia, and he has continued to publish to this date. As a matter of fact, Dr. Gordh was one of the first to publish an original work in our own neophyte publication, Regional Anesthesia. Dr. Gordh has already received the Order of the Swedish North Star and the Finnish White Rose in recognition of his contributions to anesthesiology in those countries. Today it is my pleasure, on behalf of the American Society of Regional Anesthesia, to present to him the Gaston LABAT Award for his pioneering work in regional anesthesia. Ladies and gentlemen, it is my pleasure to present to you Dr. Torsten Gordh, the 1978 Gaston LABAT awardee.
It is a great honor for me to receive the Gaston LABAT Award and to be in the distinguished company of John Bonica, Daniel Moore, and Sir Robert McIntosh, who earlier have received this award. I am the lucky owner of the first edition of Gaston LABAT's Regional Anesthesia, where he describes his technique of spinal anesthesia. There is indeed not much to add. He says, from the foregoing, it is easy for the reader to understand how delicate the puncture itself is, and that the problem of spinal anesthesia is not merely to introduce a needle through any one of the lumbar spaces, but to do it correctly and neatly so as to avoid accidents. If this advice had been followed by surgeons and anesthesiologists all over the world, I think spinal anesthesia would have had quite another reputation today. About controversies. Spinal anesthesia has been used for more than 80 years and has been the object both of immense enthusiasm and severe criticism. Due to the relatively simple technique, the excellent analgesia and relaxation, and the absence of respiratory tract irritation, which can be obtained with this method, it probably has been employed at times on excessively broad indications. Criticism has been leveled at spinal anesthesia due to complications that may appear both during and after anesthesia. Medico-legal actions have directed considerable attention to the neurological complications. Indeed, some authors have even claimed that such complications are extremely common and that indications for spinal anesthesia should be very strict, or the method should be avoided entirely. I gave my first spinal anesthesia in 1936 as a resident in surgery. My interest in spinal anesthesia continued during training with Ralph Waters in Madison, Wisconsin, 1938-39, and during my visits to other anesthesiology centers in the United States before I returned to Sweden in 1940. Milton Peterson and Emery Rovenstein in New York, Urban Eversole and Leo Hand in Boston, Ralph Tovell in Hartford, Ralph Knight in Minneapolis, John Lundy and Thomas Seldon in Rochester, Minnesota, Charlie McCuskey in Los Angeles, and Henry Ruth and Philip Woodbridge in Philadelphia all gave me valuable information and advice. Complications. In Sweden, spinal anesthesia also has been the object of controversy. In 1947, a thesis on neurological complications after spinal anesthesia and results from 2,493 follow-up cases was published by Torsten, a surgeon. He used a questionnaire and found that neurological deficits as a sign of medullary lesions appeared in approximately 1 in 200 patients. This work caused a rather sensational discussion in medical circles, and as a result, in many places, the use of spinal anesthesia was restricted considerably. However, our experience at the Karolinska Hospital, where at that time we used spinal anesthesia with great advantage in about 20% of all anesthetics, did not concur with the above discouraging results. We could not understand how so high frequency could develop, as the only complication we saw was headache. And because we had not done a thorough investigation, we decided to investigate the complications of all spinal anesthesias given during 1 year. This work published, oh, that's wrong. I'm sorry. There is something wrong with that. This work was published by Ulrich Arner in 1952. And we found that at least in our own institution, with this technique and indications developed during the years, we couldn't find such a high frequency of complications. There were headache, 3.6%, dizziness, 0.6%, backache, 2.2%. Only in one case was there a nerve injury due to spinal anesthesia. The symptom, a transient local impairment of sensation in the skin around the anus, was of minor importance. The Torsten and Arner investigations may be considered as extreme. The first was done at a hospital where no continuity in puncture technique existed and where the puncture was rather rough and performed with large needles. Further, spinal anesthesia had been used too routinely without special indications concerning age, sex, physical state, and mental constitution. The material also dates from a period where special anesthesiological viewpoints were lacking. Arner's work dates from a period 10 years later and from a clinic where the indications had been restricted gradually and the technique refined. And the general development of anesthesiology closely followed. A difference between these two investigations, therefore, is to be expected. In any case, it is important to remember that severe complications can occur and spinal anesthesia should be managed with the same respect as every other form of anesthesia. The reduced incidence of spinal anesthesia complications, of which the main one is headache due to leakage of liquor extradurally, I attribute predominantly to attention to two details: use of the finest possible needles and a special technique using extradural negative pressure as an indication of the position of the needle tip, and secondly, the gradually gained ability to select patients suitable for spinal anesthesia, or perhaps better, to select the patient with whom spinal anesthesia should be avoided. And now to the hole in the dura. In spinal puncture, a channel is made through the tissues from the skin into the dural membrane, while the extradural tissue, skin and muscle, have a strong tendency to close such a channel. This does not seem to be the case with the dura itself. The dural membrane, varying between 0.3 and 0.5 millimeter in thickness, is composed of fibrous connective tissue with rather copious interspection of mainly longitudinal elastic fibers. The inner and outer surfaces are closed with the lamina and endothelia. A needle inserted through the dural wall tears off a number of fibers composing the wall, and a permanent opening ensues. which is present for at least 2 weeks. I will demonstrate the post-mortem findings in the dura of 2 days after, 2 weeks after, and 40 days after the spinal puncture. Two days after the spinal puncture, you see the crescent-like hole macroscopically in the dura, and microscopically there is fresh edges. The hole is opened. After 2 weeks, you still can observe macroscopically an opening in the dura, and microscopically in the periphery of the wound there is a healing going on, but the hole is still open. 40 days, there is a scar observed in the dura, and microscopically the hole is healed entirely with connective tissue. This shows that there might be a passage through the dura longer time than we generally believe. The finest possible needle will cause the smallest hole in the dura and consequently the least leakage. Since 1943, we have used this fine needle, which we call Antoni needle, 0.5 millimeter in diameter, and we also use the size introducer, as a needle is too fine to be used by itself.
Doctor, one moment, please.
So this is our technique in spinal anesthesia. We always use a hanging drop to locate the epidural space when the drop, not always, but maybe sucked in. But the drop, I think, is more important to locate the positive pressure intradurally. Then the drop is falling. If you don't have the drop, it might take too long time for the spinal fluid to pass through this fine needle, so you might lose your patients and go too far with the needle and maybe puncture a nerve root. So by this technique, you just pass the dura and don't go any longer. How much do you think may leak of spinal fluid from the intradural space to the epidural space? You can make an investigation as the following. This needle, 0.6 millimeter, is placed in the extra epidural space. And there is a loop with a glass cylinder where the pressure is held at the normal leak-wall pressure, 110 milliliter. And if there is leak-wall sucked into the epidural space through its negative pressure, and by keeping this level constant, by dropping saline in there, we found that during 24 hours, 280 millimeter of fluid could be obtained in the epidural space. The normal production is between 300 to 500 for 24 hours. So it can be a considerable leak through the hole in the dura, which also will explain the post-spinal headache. And now to the selection of your patient for spinal anesthesia. At an earlier investigation, it was observed that post-spinal headache was more common in patients below 40 years of age. Later, we noticed that it was more common in female patients, in asthenic, nervous, and patients with sensitive intellect, and particularly in patients with a low pain threshold. The psychic factor is no doubt of great importance. Picnic individuals, on the other hand, are more suitable for spinal anesthesia. So, with increased experience, you gradually get an ability to select the right patient for spinal anesthesia, and the incidence of the headache will also decrease. Of course, curare and other muscle relaxants have decreased the indication for spinal anesthesia. However, a special group of patients may be reserved for spinal anesthesia according to our experience. Middle-aged, robust, muscular, and obese patients in abdominal or lower extremity operation, especially if the respiratory tract is affected with chronic pharyngitis, bronchitis, or cardiac insufficiency with pulmonary congestion. Even for a trained anesthesiologist, these patients are difficult to handle with general anesthesia, since it is difficult to keep the airway clear, and coughing and laryngospasm and bronchospasm is common. Intubation is also difficult in these patients who often have a short, thick necks with strong muscles. Without intubation, the whole anesthesia period might be a fight to clear the airway that could result in serious anoxia with a risk for cardiac arrest. Observing details in spinal anesthesia is important to prevent getting a too high spinal anesthesia. One possibly overlooked detail is the length of the back. Years ago, we did an investigation of the distance from the prominence, vertebra prominence on the neck, down to hiatus sacralis. And this varied between 55 and 75 centimeters. So with the same technique, you get the higher spinal anesthesia on a patient with a short back than in a long back. That is a detail to think of. And now to prolongation of spinal anesthesia. In 1953, Olof Norlander introduced the use of noradrenaline in the clinic. And at that time, my assistant, Sten Otto Liljedahl, he is now a professor in surgery, he did an investigation and wrote a thesis about prolongation of spinal anesthesia by adding noradrenaline. The addition of 1 milligram noradrenaline to 18-20 milligram tetracaine prolonged the duration of both motor and sensory anesthesia about 60-70%, and enabled operations to go on 3 to 4 hours. And this prolongation was thought to be attributed to the vasoconstrictor effect of noradrenaline on those vessels from which absorption of the anesthetic agent occurs. Elimination of noradrenaline from spinal fluid was found to be very slow, as shown by the slight increase in urinary output compared to intramuscular injection. So there was no effect on the general blood pressure from this intrathecal injection of noradrenaline. 1960, Klingenström wrote this thesis, the effect of ergotamine on blood pressure in spinal anesthesia. We try to keep the blood pressure, the normal systemic arterial pressure, and take measures to counteract the blood pressure fall from the sympathetic paralysis in spinal anesthesia. Klingenström showed in his work that if the effect of ergotamine on the blood pressure, and this preserves, doesn't raise the pressure, but it preserves the blood pressure. And this is a case of prostatectomy, suprapubic prostatectomy, according to Millin, on a 72 years old man. He had original pressure of 190, and during the spinal anesthesia given between L3 and 4, 1.5 milliliter of tetracaine, he reached the level of D6-5. He had there a rather pronounced blood pressure fall down to this level where it had to be treated. And 2 years later, this patient had a hernia in the scar and was operated, and he was given exactly the same anesthesia with the same amount at the same level. In addition, he was also given ergotamine as an Orstanorm injection before, and you see this time he keeps the pressure rather steady in contrast to the first operation. We can consider a high spinal anesthesia as a functional hypovolemia. Patients under high spinal anesthesia are more sensitive to supplementary agents such as intravenous barbiturates, and I will demonstrate that in the following experiments in the rabbit, which I haven't published earlier. This is a normal rabbit in urethane anesthesia. This is respiration, blood pressure. He is there given 0.5 milliliter of narcotal, which can be compared to pentothal, and there you see the respiration is stimulated, affected, little depressed, but complete recovery. The blood pressure goes down, but it gradually recovers. A typical effect of an intravenous given barbiturate to the rabbit. If you, on the other hand, bleed 50 milliliter of blood from the intact animal, you see you get the blood pressure about between 40 and 50. Hypovolemia. And if you to this animal give the same amount of narcotal, you see the following effect. There will be a respiratory depression to respiratory arrests, and the blood pressure will go down to further shock levels. If you, to the rabbit in the same shape, give the high spinal anesthesia up to D2-3, you get the same effect as you get after the bleeding. Respiration, blood pressure down against the shock level, and if you there give the same amount of narcotal, you see these curves are nearly exactly parallel to the curve where with the rabbit which was bled. So this shows that high spinal anesthesia acts really as a functional hypovolemia. After high spinal anesthesia up to TH4, you see there is a lowering of the cardiac output, a lowering of the stroke volume, an increase in the pulse rate, and during head-down position on this patient, you see the improvement in cardiac output and stroke volume. What is the primary feeling of warm caused by in the patient? The first sensation a patient feels, the first symptom after spinal anesthesia, is a feeling of warm in the feet. And in all the textbook, they say the first thing the patient notices is greater warm in his lower extremities, the result of sympathetic paralysis and an increase in continuous blood flow. I always thought that too, but I also thought that this feeling of warm comes too fast. So I started an analysis of this phenomenon. Analysis of the sensation of warmth in the lower extremities as a primary effect in spinal anesthesia. This is a curve from a temperature measuring with thermocouple from the feet, left back of the foot, right back of the foot, the heel, and this is a temperature in the room. This figure should be read from right to left. There, spinal anesthesia is given, and within half a minute, the feeling of warmth comes in the patient without any increase in the temperature. This increase, in this case, where the anesthesia level was T2, it takes 4 or 5 minutes until the temperature rises. There, you have the effect of sympathetic paralysis. In low spinal anesthesia to S1, there is a level, a saddle block. Spinal anesthesia is given there, and there the patient feels the warmth in the leg, in the feet, but there is no rise in temperature. So this anesthesia does not reach up to the level of the spinal outflow. The last outflow is about L1, L2 down to the leg. So if you have anesthesia up to here, this level, there will be no effect on the sympathetics. And this analysis I further developed by using the infrared thermography. And this is a unilateral spinal anesthesia. On this side, this patient was lying on his side for half an hour, so I got an anesthesia up to D6 on right side and up to S1 on the left side. So this is before anesthesia. He has, the light is warm, the black is colder. This is after spinal anesthesia. On this side, there is a total sympathetic paralysis, and not on that side, S1 and D6. So that is the effect of sympathetic paralysis. I have also used here a temperature provocation technique. If you put the patient's arms in warm water, you get a generally increased temperature by signals up to hypothalamus. There will be a generally sympathetic activity. And if you put the patient warm in cold water, there will be a decrease in the temperature in the body. So here is a provocated warm temperature. You see, sympathetic activity still is there in that leg and also there. But in cold provocation, this is unaffected because there is sympathetic paralysis. But this shows there is still sympathetic activity on the side which goes up to S1. And this is low spinal anesthesia. Before, after spinal, there is no sensation of no warm, no high temperature, and this is warm provocation. You see, in both sides, there will be an increased temperature rise due to the reflex through hypothalamus. And the real test of that this is not caused by a sympathetic paralysis is the following case. A 45-year-old man was amputated below the knee. 2 years later, the bone end should be revised surgically. And I gave him a spinal anesthesia lying on the sick side, and he got the feeling of warmth in the phantom foot. There is no recirculation, no blood. So the feeling of warmth just following a spinal anesthesia, I consider is a direct stimulation of the anesthetic solution on the thermal fibers. Stimulation of the warm fibers or maybe depression of the cold. And the next chapter is how many spinal anesthesias can we give to the same patient without danger? I have a patient, 67 years old, who I gave 81 spinal anesthesias. He had a papilloma of the bladder, and during 24 years he was checked up or treated 88 times. I gave him all the spinals, the first 20 with tetracaine and the rest with xylocaine. All were given between L3, 4 or L4, 5. After 77 spinals, the patient underwent a thorough neurological investigation. I thought first to do a myelogram, but the professor in neurology said, if there is no symptoms, it's not only wrong, but also unethical to do a myelogram, because the resorption occurs through the ventricles and the patient can get passing headaches and troubles. So he went through a very thorough neurological investigation with all their facilities, and all the findings were quite normal for the age. This was after 77 spinals. After 81, the patient died due to metastasis in the pelvis and the lungs. And at the section, I asked the pathologist to take care of the dura from T12 down to the bottom of the dura. And those sections I'm going to show are those with circles, with L2, L34, L45, and the bottom. This is a L2 where I never was with the spinal needle. This is a arachnoidea, and this is a dura, and there is a nerve tissue, normal. This is in the level of L34. The arachnoidea is there sprinkled, and there is a dura, and the nerve tissues and vessels here. If we go another step down, the arachnoidea, normal, the dura, nerve tissue, normal for the age. And the lowest section, there we see a little edematous edema with leukocytes in the dura, little and large, the arachnoidea, and here is a dura. So the findings are extradurally due to the small microscopically bleeding from the passage of the needle. So at these patients who had received 81 spinal anesthesia during 24 years, there were very small changes. And the nerve tissue was apparently normal. Now I come to some statistical work about present indications and frequency of spinal anesthesia at our hospital. This shows a type of surgery, and this shows different time periods. 67, 69, 3 years, 75, 77, 3 years. How the frequency of our spinal anesthesia has changed. In abdominal surgery, we have gone down with spinal anesthesia. We very seldom use a high spinal anesthesia due to the vagal reflex, hiccup, vomiting, nausea, and so on, which is disturbing. And we also think, like Nicholas Green, that a high spinal anesthesia is a more physiological trespass on the body than a lower one. So we have special indication for high spinal anesthesia, but it has inclined in use. Urology, spinal anesthesia is a method of choice still. Cystoscopy too in the male. And female genitals, we have increased the spinal anesthesia frequency because the treatment of cancer treatment in the middle-aged woman. Obstetrics, very little spinal anesthesia, and in trauma orthopedics we still use spinal anesthesia, knees and hips and so on. Vascular, long time operations doesn't suit for spinal, where we use continuous epidural. And this is distribution according to age. You see, the most frequent spinal anesthesia group is the middle-aged man. And during the years 1967 to 77-10 period, you see the level of the frequency of spinal anesthesia has been rather steady in spite of the addition of all these muscular relaxant agents and neurolepts. So it's still a clear indication for spinal anesthesia, at least at our hospital. And I will end my lecture by a citation from LABAT. The safety of intraspinal block depends on the height of puncture, the anesthetic agent, the pressure of injection, and above all, the experience of the man who uses it. I think he is still right. Thank you.
We're taking advantage today of the fact that Dr. Torsten Gordh is in the United States, his being one of the pioneers in regional anesthesia, to have a little chat with him and ask him to share some of his experiences as he first trained for his role in regional anesthesia and in anesthesia in general, of course, and then as he returned to his native Sweden to begin to develop anesthesiology in that country. Torsten, you arrived in Madison at Dr. Waters' department in, I think you said, October of 1938. What did you find in terms of regional anesthesia? Was it used widely, or wasn't it, or were there many techniques? What did you find?
I found that, no doubt, inhalation anesthesia dominated. There was only occasionally spinal anesthesias. So it was not widely used. I think I should appreciate maybe maximum 10% of regional anesthesia.
Was there any particular reason for that? Was it that they feared spinal, or was it that general was growing so fast and becoming so important?
No, I think it was due to the cyclopropane introduction and so on. So it was a continuation of the ether and nitrous oxide inhalation anesthesia.
So it really overshadowed regional anesthesia.
That was my impression.
There were none of the fears that some people have today about
No,
the
no,
spinal and
no, not at
regional
all.
anesthesia?
It was just that inhalation dominated at that clinic.
Well, was it a problem then to learn to do the various techniques of spinal and so on?
Well, for me, it was no problem because I had used spinal anesthesia very much during my 3 years as a surgeon.
That's right. As the junior surgeon
Yes.
resident, you were delegated the job of giving anesthetics.
That's right.
Was it usually, because you had nurse anesthetists to do general, then did you, when you were in Sweden and when you were still a surgery resident, did you only do the spinals and the things that could be done under regional?
The surgeons himself did the spinal or the regional anesthesia.
Is that right?
Yes.
In
In those patients he was going to operate upon, he did it
and
himself.
did anybody monitor them then, following their course to make sure they weren't too hypotensive or?
Of course, you always had some senior man behind you, which was more experienced.
I see. So if you got in trouble, he could bail you out, huh?
That's right.
Then in getting back to Madison, was there any role for anything other than spinal in 1938? Was epidural a rare event? Brachial plexus block? Was that something unheard of?
It was just spinal anesthesia.
That was it.
That was, I think, the only regional type of local anesthesia.
So you really, in terms of other regional anesthetics than spinal, you really had to pick that up on your own.
That's right.
When you got home. Well, when you did get home, now you stayed here 2 years. You went home in December of in 1940.
1940, yes.
I think you said the day before Germany attacked Norway and Denmark.
8th of April, 1940.
Right. When you got back now, you had a staggering challenge ahead of you. What was the status then of regional in Sweden at that time? You've already said that the surgeon usually gave his own spinals, but was this a large part of the anesthetics, or was that only occasional?
It was in different clinics and hospitals. Some method dominated. In some clinics there was inhalation anesthesia, and some there was more local anesthesia, in some there was more spinal.
I see.
And I never forget 1936, I attended a surgical meeting where anesthesia was in discussion. And when the different professors in surgery stand up and say, if I want to have an anesthesia, I like to have it in local anesthesia. Another said, I would like to have nitrous oxide ether. Another said, I like to have it in spinal. So everybody had to choose what they are used to. There was no one who could master all of it.
Oh, that's very interesting. There was a survey over here about 10 years ago, where they asked doctors, anesthesiologists, what they wanted, and about 70% wanted regional anesthesia for
That's
themselves.
interesting.
So it's...
they wanted the type of anesthesia which they are used to.
Right, right. Well, that's interesting. Did you, as you looked and started working in your own country with a lot more training than you had before when you were doing anesthetics, with respect to particularly spinal, but with regional anesthesia, what was the main thing that had to be done to improve the situation? Was it just, you were one man at the beginning. You couldn't give all the spinals. You couldn't do all the blocks. How did you handle that? Would you do it and have somebody sit with it and to monitor it, or?
I had, when I came 1940, the chief professor was very interested in urology. And they had used very much sacral anesthesia. I introduced epidural and sacral, but that was too time-consuming. So I had to, as one anesthetist with the help of nurses, I had to find a method which was fast and safe. And I found that spinal anesthesia was the method of choice. So that's one of the reasons why we at Karolinska Hospital has such already from the beginning a great experience of spinal anesthesia.
Of spinal.
We had to adopt that as a method of choice.
Now, when you say that he was interested in sacral anesthesia, do you mean the actual transsacral blocks?
Oh, yes, yes.
Put separate needles in each of the foramina?
No.
Or a caudal block?
It was just a caudal block.
A caudal block, I see.
Caudal block.
But certainly, I see. So you felt spinal was faster?
Faster and safer. A caudal block was not always 100%.
Right.
And even epidural at that time, they were more time-consuming and not always 100%.
I've heard you say that, and even though it's in Swedish, I've seen you show a slide showing the impact after, how many years was it you did that study on mortality?
3 years, yes.
3?
3.
And you showed that those hospitals that you had worked in and organized anesthesia, there was a drastic reduction in mortality, whereas in the ones that were still functioning under the old system, the mortality continued the same.
Right.
It's a very, very impressive piece of information. What I was going to ask you is, did regional anesthesia play a role in that at that time, or was it too early?
Not very much, I think.
By making it safer?
Yes, I think on the general side, the basic principles which I told about in my lecture, I think that was they who gave the result.
Looking back now on the 40 years that you contributed, how has the status of regional changed? Is it more widely accepted?
It's more widely accepted, more and more. So it is coming.
But it's still coming, you think? It really hasn't reached its...
Different types of regional anesthesia is more coming, more and more. That's right.
Let me ask you sort of an offbeat question. Certainly, starting out all alone, literally all alone, being the only anesthesiologist in the country, over the years, you must have had what we over here call fiascos, some interesting cases related to regional anesthesia.
Oh, well, there are 2 spinal anesthesias I never forget. One successful and one unsuccessful. And I can relate those cases for you. The first was a 10-year-old boy. He had a horse kick in the stomach and got a subcutaneous rupture of the guts. Was operated upon at the country hospital. Post-operatively, he got a anuria, which didn't pass away. So Professor Söderlund in Stockholm was consulted in this case. He went down to the city and took the child up to the private hospital in Stockholm, Sophiahemmet. There he did a decapsulation operation on one side first. There was no improvement. And after that he repeated the decapsulation on the other side to get the kidneys to swallow off without improvement. So there was, the child got worse and worse. And at last the situation was given up by the surgeon, by the parents. And I gave anesthesia on both operations. And then I had read, I think a paper that spinal anesthesia sometimes could lose sympathetic reflex to the kidney. Sure. So I suggested to Professor Söderlund, would you let me give him a spinal anesthesia? And I asked the parents and told them that this might be a chance. I promised the parents that the child should feel no pain. That was one of the reasons. So I put the child to sleep with cyclopropane and gave a spinal anesthesia in a lying position up to T12. And I had to test I usually test the level with cold, so the patient can tell whether it's cold or warm. But to this, I had to do like with a rabbit. I had to pinch the skin, and when I came up here, he started to move. So he tolerated this, went back to the bed, and after a couple of hours, I'll go to the child and look at him. He had a balloon at the lower abdomen. The bladder was filled with urine.
Isn't that something?
He recovered and is still alive.
Isn't that a
That
wonderful
I
story?
never forget. That was a successful spinal, therapeutical spinal.
Let's hear about the less successful spinal.
Well, that was a tall man, 2 meter long,
That's about
He was
6 feet 2, isn't it?
1942, just a couple of years after I had arrived back to Sweden. And I didn't have the pondus, the strength to do what I wanted against the surgeons, maybe. So one day the surgeon asked me, we are going to operate King Gustav V of Sweden for a urinary bladder stone. And I like you to give him a spinal anesthesia. I gave him a spinal anesthesia, and I am not allowed to give him any premedication. So, because his doctor said the king is so sensitive, so he cannot tolerate anything. So there I was with an unpremedicated king. The spinal anesthesia went very easy. He was like a cat, badly, but easy. But I wanted to have it up to the navel plane. And he refused to lie down on his back until he had got some more pillows. And until they had arrived, I knew right away this spinal anesthesia will never go up. It will be a saddle block. So I told the Professor Hellström, urologist, you must give him a little local anesthesia in the incision line. He did that, and that was painful for the king. So I put a needle in the arm and gave him a couple of milliliters narcotal. He was 86 years old, so 3, 4, 5 milliliters was enough. For a short operation, 10 minutes, the stone was out. In the afternoon, the king was lying in his bed, sewing, what was his hobby. The whole thing was over. And after that, the story goes around the world about me, that I says to the surgeon, the old man is asleep, and then the patient says, the old man is not asleep. So maybe it is something in it anyway,
Right.
after I told you.
Oh, that's wonderful. Let me just ask you a couple of questions that you could maybe answer briefly. You're well known for tackling the problem of spinal headache.
Mhm.
How did that come about, that you did that piece of work ultimately that seemed to solve the puzzle?
One day, my assistant, Frankson, came to my office. He was my assistant, and he came down to my office, and I told him, on the shelf there, you'll find 3 bottles. One contains a 2-days-old piece of dura of the spinal, and one 2-weeks-old dura of the spinal, and the third 40 days. So I said to him, let's make an investigation, histopathological of this. And he wrote that paper, we wrote it together, and it's now a classic.
Right. But you...
So I always interested in this complication. Wanted to find out.
It certainly became a classic in the literature.